Hello, everyone. My name is Snail Desai, and we are going to go over some cardiovascular topics here. One of them, which is the heart failure topic. Um, just going to briefly go over the mechanism of some classes of medications. Some of you probably already familiar with them. Um, I'm not going to explain all of them because some of them were already covered in my previous uh, lecture where I discussed the heart hypertension medication classes mechanisms. So this section is going to go over some of the other mechanism of drugs that's used in treating heart failure. So you can see here some of the topics, as I mentioned in the hypertension lecture. These are pretty much the basic topics that you should have in understanding for preparing for the NAPLEX. And most of the, like I mentioned earlier, you're going to see some overlapping of some of the classes of medications that's used in multiple disease states in the cardiovascular section. So that's pretty much that. So in terms of heart failure, there are actually two types of heart failure mechanisms that might happen. So you can see here, there's a heart failure reduced ejection fraction, which is HFrEF. And then there's a heart failure preserved ejection fraction. So what is the difference between them? Well, heart failure reduced ejection fraction, hence the name reduced in the name HFrEF, is basically meaning that the blood is not getting pumped out of the ventricle properly because it's just reducing. I guess you can think of it as like reduced ability for the heart to pump the blood out of the ventricle. So it can't contract effectively. And so this leads to systolic dysfunction, where it's just mostly a failure in contracting of the heart to pump that blood out. Um, Whereas HFpEF, which is the heart failure preserved ejection fraction, is quite the opposite. The heart can pump out the blood as it should normally, but the ventricles can contract normally. The only thing is, it just contracts normally, but the heart is not able to relax so the blood can fill inside the ventricles properly. So that's the problem here. And you can see here the left ventricular ejection fraction values matter. If it's less than 40%, that is going to be heart failure reduced ejection fraction. And if it's greater than 50%, then that is heart failure preserved ejection fraction. Now, in terms of the treatments, most of the treatments are used to treat heart failure reduced ejection fraction. There aren't really any medications used to treat heart failure preserved ejection fraction. Maybe you could use some medication to treat the comorbidities of, this disease, but you can't really treat the heart failure preserved ejection fraction with directly with these medications. Um, so as of right now, this is how I see it as the ejection fraction. Just understand that if you see a case study on your exam, you need to understand these differences. The at least understanding what the LVEF values are, so that you know whether it is the preserved ejection fraction or reduced ejection fraction. Reduced is going to be less than 40%, and less than or equal 40%, or great or preserved, which is greater than or equal 50%. These are some of the medications that might improve mortality in patients with having heart failure. Um, So you can see some of the medications, as I mentioned, there are some overlapping classes that you may have seen that's used to treat hypertension. So ACE and ARB, ACE inhibitors and ARBs, we have already discussed. So if you do not remember the mechanism of action of these classes, please go back to the video where this class was discussed and reviewed the mechanisms of action on these classes of medications. Um, Arni is another medication. It's a unique type of medication. It does use one of the classes, which is ARBs. In It's a combination pill. It's the two medications that make up Entresto, brand name Entresto, is sacubitril and valsartan. It's a combination drug, and I will discuss the mechanism behind the sacubitril so you understand how that works. And you already understand how ARBs work, so I'm not going to go over that in detail with you. Um, Beta blockers. The main three beta blockers that's used to help patients with heart failure are the carvedilol, bisoprolol, and metoprolol succinate. Now, there have been times when patients have been on a asthma medication for bronchodilation or bronchodilators to help with their breathing. So you might see carvedilol being used at the same time. So be careful with that, because carvedilol is a mixed type of beta blocker. So I would uh, like you to know these two are okay. Metoprolol succinate is commonly used, but if you see a patient case, you might notice that some of these medications are mixed beta blockers. So know what the differences are between the beta 1, beta 2 selective beta blockers. So I'm just going to display these three medications here for your reference for heart failure specifically only. Another type of medication or class of medications that's used for heart failures are aldosterone antagonists. These are medications like spironolactone, eplerenone. I have not seen eplerenone being used a lot in practice, but spironolactone is also another medication that's commonly used. They also use that to treat hypertension in a way too, high blood pressure. You'll see these medications as well. Then the next one I have here is SGLT2 inhibitors. Now, these are things like you have heard maybe on a TV commercial like Farxiga, or, you know, that as an example of SGLT2 inhibitor. It is one of those classes that's also used to treat high blood sugar levels too, or diabetes. So some of this may overlap. Some of these medications do overlap other disease states as well, but particularly in this discussion, I'm going to go over heart failure. So we are going to stick with SGLT2 inhibitors being used as a mortality benefit medication for heart failure. Diuretics, they are just mainly used for symptomatic relief. They are not really used to treat mortality or help improve mortality. It's just there to help with, some of the symptoms. Um, I'm not going to really discuss the mechanism behind all the diuretics here, but at least understanding the ACE inhibitors, the Entresto, the beta blockers, aldosterone, SGLT2 inhibitors, those are the main ones that you should know for treating the heart failure reduced ejection fraction. So know all of these. So this is a diagram of the ARNI system. What happens here? Well, the liver is primary. So the medication is first taken, and that one part of it is the sacubitril. And when it's taken inside the system, it goes through the liver, it gets metabolized, and converts into an active form. Because sacubitril is a prodrug, it needs to be activated in the system in order for it to work. So you could see that sacubitril is a prodrug. Once it goes through the liver, it metabolizes to its active form, which is the LBQ657, and then it's going to block naprolism, where naprolism is a enzyme that actually breaks down the natriuretic peptides in the bradykinin, which are the main components in causing vasodilation. So by blocking naprolism, you're actually preventing the breakdown of those other peptides. Um, so that's basically what this mechanism is. It's just going to prevent this enzyme from doing its work. So just understand, at least have a basic idea of how RNA works. Okay. Then the next one here I have is an example diagram of beta blockers. Now, as I mentioned, carvedilol is like a mixed beta blocker, so you guys see it as a beta 1, beta 2. So sometimes, beta 2 blockers, when you're blocking the beta 2 receptors, you're also preventing the bronchial tissue, which is part of the lungs, normally for helping with the airways. So here in this diagram, you'll see why you need to be cautious if you see a patient case and you see someone with the asthma medication, what heart failure medication to use. You need to understand that carvedilol probably should not be the one you should use to treat someone with a heart failure. You should probably consider some of the beta 1 selective blockers here. So, like metoprolol, and aterol, but bisoprolol, any of the beta 1 selective blockers. You want to definitely consider using those versus a mixed beta blocker so you can help patient with a heart failure. And also, continue with their asthma treatment as well, so the medication works properly. So you can see here the beta 1 receptors, the main primary places you will find them are in the heart and the kidneys, and the beta 2 receptors primarily in the vascular smooth muscle and the bronchial tissues. The aldosterone antagonists like spironolactone, eplerenone, these are the antagonists that work mostly around the kidneys, where in the nephron, at the very end of that nephron, you're going to see a convolute or collecting duct, or the late distal convoluted tubule. And what happens there is it will actually block the mineralocorticoid receptors in there, so that it can prevent sodium and glucose from getting reabsorbed back into the bloodstream. Instead, it's going to excrete it out of the system. So that's where this class of medications work. I'm not going to really discuss too much into ENaC channels, but you could see that tranturine, amiloride, those kind of medications are usually worked in this section. We'll talk about more of those in the later videos, in the later presentations. But as far as this discussion goes, aldosterone antagonists work primarily in the late distal convoluted tubule or in the collecting duct, where the mineralocorticoid receptors are located. The SGLT2 inhibitors, as I mentioned, that's another mechanism that works also in the kidneys, where the nephrons are. And This works in the proximal convoluted tubule. So it's kind of like at the very beginning where, like, the nephron, you have the glomerulus, then your proximal convoluted tubule, got the loop, then you have the distal convoluted tubule and collecting duct. So in this case, you're going to see here the medication, the blood is filtered in the glomerulus, produces filtrate that contains the glucose, sodium, and water. So in the proximal convoluted tubule, a transporter called a SGLT2 reabsorbs 90% of that glucose, filtered glucose, back into the blood, and along with the sodium. So what happens here is, when Farxiga is taken and goes through blood, and it will block the SGLT2 transporter so that none of this gets reabsorbed. And this is just another diagram showing the SGLT2, kind of like where it's going. You can see in the proximal tubule, you can see how it's kind of working to reabsorb it back into the blood. So that's why this will actually prevent it from getting reabsorbed.